Good afternoon. Good afternoon. This is Dr. Velma Scanterbury from Dialysis Patient Citizens Educational Session, and this is the Ask the Doctor live session. So it is now 4:01 p.m. and whether you are if you're on Eastern Time, you're right here with me. If you are on the West Coast, it's probably a lot earlier. So again, I will wait to see who is coming on. And let's see, make sure my volume is up. Okay. Hello, hello. Dr. Velma Scanterbury. Hi. This is Dialysis Patients Citizens Educational Center, and this is your Ask the Doctor session, trying to get some light here into my office. And I welcome all of you here. It is now 4 p.m., 4:02, so I will wait for some to join. I am sure that it's now nice outside. Folks may be out doing things. It may be a good day, and you probably trying to stay out of the heat, and we're hoping that you will join. So this is your Ask the Doctor live session, and I will be here with you whenever you come on. So I'm gonna hang tight and wait for an audience. I'm not sure about you, but it's actually 86 degrees here in Wilmington, Delaware, and compared to 95, I think that is not bad. I'm not sure that we will have any rain today, but it's been raining on and off for many days, and we appreciate the rain. So thank you, Nancy, for coming on. It's 4:03. We look like there's be a sparse audience today. So we'll see who joins, and we'll talk about a couple of things. One, maybe about caregiver burnout, what happens to the caregiver, and also patient advocacy, what we can do when patients are having a difficult time with the dialysis units. I've had some patients with that, so with those complaints. So if you have any insight, any suggestions to help these patients out, I certainly would appreciate it. While we're here, I'm going to try to see if I can bring you on, Nancy. Let's see if you can, if they will work. Doesn't look like it's working, huh? It keeps saying add in. Let's see if you get the requests and whether you're able to join. Doesn't look like you're able to join. Hello, Joanne. This is Dr. Scanterbury with the Ask the Doctor session, Dialysis Patient Citizens Educational Center. And today is Wednesday, July 16th, and 4 p.m. here, Eastern Standard Time. So let's get right into it. If you have any questions, Joanne, please put them in the chat so we can talk about it. Nancy has posted a question on PD or in-center dialysis pros and cons. I really advocate for my patients to do dialysis that's more often, daily if possible, rather than every other day in center. But if you have, there are some centers that have an evening shift or 8-hour shift, or overnight shift that makes it amenable to having the cleanse in your body in the evening, so that you are taking out all those metabolites that you consume that day. So if you have the ability to do daily dialysis, we eat daily, we build up toxins daily, and we want to be able to mimic a rhythm of getting rid of those metabolites as often as possible. When you're doing it 3 days a week, you're storing a lot of those metabolites which play havoc on our system. And the worst part about it, if in center hemodialysis, is with that fistula and that rapid blood flow from your arm to your heart, you're impinging on the work of their heart and causing significant deterioration as this waterfall comes back to your heart. So a lot of patients will find that the ejection fraction or the heart pump abilities deteriorate over years of hemodialysis. So if you are able to minimize your dialysis treatments to every day, daily, it's much better for your body. Your body becomes better synced with being in a homeostasis level, and you're able to control the complications down the line. So patients who rinse on a regular basis, 5 days a week, do much better than those. So there are some disadvantages. There are patients who don't have the ability to store equipment at home. They may have pets. That sometimes may not be a good thing when you talk about doing home dialysis, and therefore may not qualify because of the risk of infection and germs, and keeping your site clean. Some people who live alone may be fearful of doing home dialysis because if something happens, would they have help to prevent a major disaster? So, in terms of training, that's the reason why you go to training with your nephrologist to make sure that you are a good candidate. So, thank you all for coming on. Again, this is Dr. Velma Scanterbury, and I'm the medical consultant for Dialysis Patients Citizens Educational Center. So this is Wednesday afternoon, July 16th, and we appreciate all of you who can be here. I've had patients who've been on PD for many, many years, did well. There are those who will develop a thickened abdominal membrane where your peritoneum lining of your abdomen gets very thick, and therefore there's lack of ability to exchange um, those things that need to be exchanged across your membrane, and it makes it difficult to actually perform the dialysis. So patients will have to switch from PD to hemo because of those issues. Some patients get repeated infections, exit site infections, peritonitis, causing a lot of scarring and adhesions within the abdomen, and therefore have to not be and are unable to successfully dialyze them because of loculation of fluid around the membranes that are formed, not being able to get the fluid out. So while I do feel like it's an excellent way to perform dialysis, as when it comes to renal replacement therapy, it can be a challenge for some people. But if you're successful, it's definitely the way to go. If you're older, and over 75, even if over 70, and need to be on dialysis, that's generally my recommendation. So it's a lot easier on your system. There's less heart issues, and less hypertension. And people who have significant heart disease can be most challenging with hemodialysis. So thank you all for joining. I appreciate you being here. And there's another question in the chat. Please feel free. Don't let Nancy add all the questions, but feel free to ask your questions. Sepsis is frightening. What can patients do to avoid sepsis? It's about keeping your sites clean. Any site whether you have a catheter, whether you have a fistula, whether you have a PD catheter, there's always an opportunity for skin flora to make its way into your bloodstream from the outside. So you want to make sure that area is cleansed. You want to make sure that it's kept free of dust and dirt. If you're in the garden, make sure you protect your sites from any contamination with soil. If your dressing comes loose, you want to make sure that it's cleaned and replaced appropriately, especially if you have a catheter. for PD catheters. They actually tunneled into your skin, but they go under your skin and muscle before they dip into your abdomen. So you can have a exit site infection and not necessarily get peritonitis because it doesn't travel, may not be able to travel along the site. But you have to be certainly clean. Make sure you use the safest techniques, hand washing, careful with contamination, and in terms of not assuming that okay, it's going to be okay if it got contaminated. Make sure you wipe it off as clean as possible. Change dressings. Oftentimes for exit site PD catheters, you're given some gentamicin cream to take care of that. So those are things that you want to do to make sure that you keep yourself free of infections. If this uterine line gets infected, it's going to need to come out or treated if that's your last source of dialysis. But I wanted to also touch, since there are no other questions, on talking about your caretakers. And many of you who have had been on dialysis, your spouses, your loved ones, can often go through a very challenging time dealing with your illness, taking care of you, your demands, and you know that we are not always in the best mood and can be challenging to those who take care of us. So it is important to make sure that you allow your caretakers to get a break, to really have some time down to themselves, maybe rotate with others or spend some time with other people so that you can allow your caretakers breathing room and be able to say, okay, maybe I can alternate with other family members. You can alternate with some friends, Sunday off, a Saturday off, so that they can do things that they themselves can get to the doctors and that they are not missing their appointments. And most of all, if your loved one is a family member and there's any chance that they may have the same disease that you're suffering from, that you want to make sure that they get appropriate care and get appropriate monitoring. So always think about the person taking care of you, the person picking you up, the person who's helping you, the person who's making dinner for you. If they're there all the time, then you want to make opportunities for them to also take care of themselves and not go through burnout so that they end up in a position where they're also going to need help. So again, I'm Dr. Velma Scanterbury. I'm the medical consultant for Dialysis Patient Citizens Educational Center. And let's ask some questions. Let's keep it going. Tell me about your day. Tell me about what troubles you're having on dialysis, or after transplant. Or is your transplant, you have issues with virus infections? CMV and BK virus are the two most common viruses that we see post-transplant. And some people can lose their kidney because of these issues, because it can really multiply in the kidney, cause BK nephritis, nephropathy, scarring in your kidney. You see this inflammation, and it can cause your kidney to deteriorate. Many patients also face what we call development of post-transplant, antibodies, donor-specific antibodies that come into play after you received your kidney and you didn't have antibodies before, or that wasn't detected. They weren't detected prior to transplant, but now this kidney is in place and your body has developed antibodies against this donor kidney and is trying to slowly reject it. And there's a constant need of monitoring. There's a constant need to check to see whether you need to be treated for rejection. And with more and more medications for rejection, guess what happens? You lower your immune system, and then those viruses that were dormant at one time are now rising to appearance because now they have been uh, uncloaked. And so we then, things that we carry around are now able to become more prominent. So BK virus actually is what we call the polyoma virus, and it's called BK actually after the very first patient who was diagnosed with this many years ago in California. 80% of patients, 80% of us carry around BK virus. It's like a cold virus, but unfortunately, it doesn't cause the average person any issues. Same CMV is cytomegalovirus. These are viruses that the majority of the population have, but because our immune system is adequate, we can keep them suppressed. And unfortunately, when we're transplanting and all the extra immunosuppression that we're given suppresses our body's system to respond, then these viruses that live dormant, viruses don't ever go away, they just stay dormant, can rise to the surface. We now have a way of detecting the presence of these viruses. They're shedded in our urine, BK especially, can live in a transplant kidney. It can be in your own native kidneys, as we know that bone marrow transplant patients, they get in bone marrow, but the immunosuppression, they also can, you can see BK virus after a bone marrow transplant. So it's in your presence in your kidney. It can appear in your urine, and after it gets to be thousands of copies in your urine, it can spill over and be in your blood. And because you're immunosuppressed, that virus can cause nephropathy as it multiplies tremendously in your transplanted kidney. So it has, sometimes you have to lower the immunosuppression, allow your body to take care of that virus. Oftentimes there may be some antiviral treatment that you can use. So monitoring BK virus is important, and especially some centers would do it every month for the first 3 months, then maybe every 3 months, and then every 6 months, depending on whether it's ever appeared. Low numbers are not necessarily anything to be concerned about. If it's less than 10,000 in the urine, this may not necessarily be a concern, but you want to follow that. If it gets up to 1 million copies in your urine, you're then looking to make sure it's not in your bloodstream. So thank you very much for that question. Lupus, a question about lupus. Can a patient with lupus, can a patient get a transplant if lupus is now in remission? Certainly, if your lupus is flared up, you're not getting a transplant because your antibodies to that lupus stimulus is active. And so what happens is that in the presence of, if you're not in remission, it can appear in your transplanted kidney because the same drivers of those that lupus to your native kidneys can attack your transplanted kidney. So we usually will wait to make sure that patients are in remission and at their lowest level of medication to control their lupus. If they're still on 20 milligrams of prednisone to control their lupus, generally it means that post-transplant, uh, it may not be as quiescent as you want it to be, and you have that chance. So we usually want for patients to get down to 5 or 10 milligrams of prednisone because that same prednisone may need to be continued after transplant. However, the other transplant medicines may also play a role in keeping your lupus under control. But yes, it does have to be in remission before you can be transplanted. My mom has been on dialysis 12 years and she is well taken care of by me and just having trouble with them adjusting her dry weight. And I'm on top of her care. So thank you so much for taking care of your mom and keeping her in good health and making sure when you say that you are advocating for your mom. You're keeping her out of trouble, and making sure that you're doing the best by her by not drying her out, but making sure that her blood pressures aren't dropping. Those are things as you get older, you want to make sure that there are not too many shifts in your blood pressure on dialysis. So thank you so much. My husband lost his first kidney transplant to BK, has his second kidney transplant now 2 years out, and just showed up now and then. Otherwise, he's doing well. How long before the kidneys react is really about um, controlling the virus, and it's really a balance of immunosuppression, risk of rejection. Uh, we used to have an argument that if you had BK in your previous kidney and you failed, is it necessary to take out that transplant before you get another transplant because of the issue of maybe there's kidneys harboring BK? It didn't really seem to matter. What it matters is that where your where you are in terms of stability of not having rejection and controlling that virus. So you want to make sure that they're keeping on top of what's the count of that viremia coming out of his transplanted kidney, and also checking to make sure intermittently, if it's on the rise, that you're checking to make sure it's not spilling over in his blood. And certainly you can, because you will have uh, underlying chronic inflammation because of that BK nephropathy after a certain number has multiplied in your kidney. So they really do have to, some patients will stay stable with a small count, less than 50,000, and do well for many years. So it's about really seeing how you can minimize immunosuppression but not prevent rejection as you continue to monitor the BK virus. Thank you very much for that question. Thank you all who continue to stay with me. Again, I'm Dr. Velma Scantberry. I am the medical consultant for Dialysis Patient Citizens Educational Center, and I practiced as a transplant surgeon for nearly or over 30 years, and so have significant experience with kidney transplant. While I started as abdominal transplant, doing liver and pancreas transplant as well, certainly as my career progressed and moved to various transplant centers, kidney transplants became the one transplant that was a continued need and continue to be important in my career. One, because I think there's a need for better advocacy and really looking at uh, the disparities or the lack of access that some patients have to transplant, the misinformation that can often be uh, given to some patients who, with not knowing that they can apply for transplant without being needing to be on dialysis. There's so many patients feel you have to go to dialysis before you can qualify for a transplant. That's not true. Many patients can go to end-stage renal disease without dialysis straight to transplant or to the list, because you can be listed long before you need a transplant. And so that's important to know. If you have a living donor and you're in stage 5 or 4, even to 5, you can plan to have that living donation long before you hit dialysis, and you can avoid dialysis. So those are things in terms, and it's important as you optimize your condition to get transplant. You want to make sure that you control your diet, that you keep your phosphorus under control. That is most important because phosphorus builds up in the lining of your vessels, leading to significant atherosclerosis and difficulty when it comes time to transplant. And you see that calcification from calcium deposition because of the phosphorus calcium imbalance in the blood vessels, and many patients are turned down because the inability to find an area to really connect that kidney. So when it comes to keeping on top of your numbers, making sure you're not anemic, making sure that you control your phosphorus. If you are doing everything by diet, there are some newer medications out there that can help keep your phosphorus under control. Yes, I make she goes by her Rena diet, all medications taken, all appointments are taken, never miss them, and she has been having low blood pressure past few weeks. What causes it to drop, like during dialysis? And so as we get older, or depending on what your underlying disease is, let's say you have diabetes, you're going to have some vessel issues as a drop in blood pressure. If you've been on dialysis a long time, you can somehow want to make sure that your heart pumpability is adequate. So we see oftentimes with long-term dialysis patients is that with the hemodialysis, you end up with your ejection fraction and your ability of your heart to pump out gets less and less, and so your blood pressure may be lower. If you're on hemodialysis, uh, the amount of blood that's out of the machine compared to what is going through your body can cause low blood pressures during that time. So you want to talk to your doctor about what's causing the low blood pressure. Diabetes in itself can do that. So some patients with low blood pressure may have to be on midodrine to help raise that blood pressure. So a few minutes left. Question about parathyroid. We know that that plays an important role in your calcium phosphorus metabolism. Oftentimes patients will develop tertiary parathyroid because your calcium is low. Your parathyroids are trying to put out more calcium. They do overwork, you get a parathyroid adenoma, or you get parathyroid hypertrophy, and now they're working overtime and they're doing things they're not should be doing. So when it gets out of hand, you then have to say, okay, we got to turn this off, because what happens, your PTH gets very, very high. You need more and more Sensipar. At a certain level, the Sensipar isn't working, and your body is seeking calcium out of your bones. So that is one of the things you want to make sure, and I'm sure your nephrologist is keeping on top of your PTH level to make sure that you don't need to have a parathyroidectomy or partial parathyroidectomy to control, to bring your PTH level back down so that you don't have that abnormal calcium phosphorus level. Another question is, how do one keeps the BK virus in check, and what are dangerous levels for most centers? Some centers are still doing urine. It's the easiest thing to do. You get a urine to check for BK virus. You measure the counts. You see what's going from month to month or every 2 months. If it's stable, if it's less than 100,000, some centers do not react. They try to see what's going on. Uh, at some point, if it continues to climb past 500,000 copies in your urine, it's probably time. And each center has the protocols. Don't get me wrong about when they intervene with the blood to check the blood. Some centers never check the blood, and go by the urine. And oftentimes, when the creatinine starts to rise and the BK virus appears in your blood, now you're behind the eight ball. So just find out what's the protocol for your center. Is it 500,000 copies, a million copies, or 100,000? Each person has a different tolerance for when. Just imagine if the virus is in your blood, it's now more dangerous than if it's confined to the urine. So for each person, that may be different. Please join us on every third Wednesday at 4 p.m. on Facebook for this session, and I really appreciate all your questions. We've had a robust conversation, and I really hope that this is educational for you. And I said, this is Dr. Vermont Canterbury, and I am trying to make sure that I answer all your questions. If not, I will try to get to them on Facebook so that we can continue this conversation. And also, if you have other questions, as this posted on Facebook, I will try to also look for those questions that have not been answered. But I really want you to focus on two things: controlling your blood pressure, following up with your cardiac, your heart doctor. If you have one, make sure you're keeping your volumes down, especially with the summer. I know it's hot out there, and um, she's been on dialysis 2011, have had gotten both my kidneys removed. I'm on the list, and I'm looking forward to getting transplant soon. I just want those who are on dialysis to know that in struggling, just stick with it, because you're going to get the help. God's going to get you through this, and that is so true. So I really appreciate that. For a good ending, know that you're not alone. And that there are hundreds and thousands of patients who are on dialysis. But you have to keep your hope. You have to maintain your hope that this is not going to be it for you, and that there's something better. Now, granted, not everyone will get a transplant, and not everyone will do well on a transplant, but we want you to live your best life, and we want you to be able to see positive outlooks when you're on dialysis, and knowing that you can still have a life despite being on dialysis. So thank you so much. I appreciate all of you being here today, and I will see you again next month. So take care. God bless. And remember, I think there is a session on dialysis patient education on Sunday. Take caretaker burnout. No, it's Be Your Own Advocate, Sunday, August 17th. Please check DPC website for many more educational seminars and insights and places you can log on for more information. God bless. Take care.